Welcome to the other side of Lucy Letby. In episode 46, we're going to look at the death of baby P and look at the similarities between the death of baby P and baby O, who was his triplet sibling. Baby P, for me, is one of the most astonishing performances by Jamais. Truly astonishing, and it demonstrates perfectly his modus operandi. Unlike most doctors who start out with a bunch of symptoms that lead to observations and findings that lead to diagnosis, Gary starts out with a diagnosis and then he goes hunting for symptoms and signs and observations and findings to prove his diagnosis or his theory or his invented illness correct. Can we all imagine how chaotic that would be if that were the case in real life? And in this case of baby P, we're going to see Sandy Bohan charge headlong into a brick wall and completely demolish her own argument. Before we have a look at the public record of baby P, and there isn't much information in the public record about baby P, let's paint the picture of how this prosecution works. Baby O and baby P have abdominal distension, apnea attacks, and eventually collapse and death. The name of the game is to make sure that the consultants at the Countess of Chester Hospital are never blamed for any actions or inactions taken during the care of the baby. And therefore we have to steer the jury away from the possibility of negligence and keep the jury firmly focused on the fact that Lucy Letby is obviously a murder. We look at the two predominant symptoms of both baby O and baby P. They have very rapidly advanced enteral feeding, that's feeding express breast milk, mostly through nasogastric tubes, and reaching full enteral feeds by 36 hours. We don't know how many stools or how much meconium each of the babies have passed. That's the first series of normal bowel movements that these little preterm babies have. And we know that at least for some of the time, and probably all of the short period of time they were alive, they were on high-flow nasal cannula. We know also that there were triplets delivered by emergency cesarean section, and we know from the father's statement that he said when the incision was made for the cesarean section, a lot of amniotic fluid splashed against the wall of the theatre, and we have no idea how easy or difficult the delivery was. We have no idea if there was any triplet to triplet transfusion in utero and selective intrauterine growth restriction. We don't know anything really about the antenatal history at all, but it's perfectly feasible that both of the babies, baby O and baby P, suffered liver injury at birth because it is a well-known cause of subcapsular hematoma. In the context of injury at birth, very often the hematoma will not become apparent until 1 or 2 days later, and one of the presentations can be abdominal distension and increased feeding intolerance. But no doctor would be surprised by the fact that there is even controversy over how you define feeding intolerance in preterm neonates. Let's look quickly at an article from a journal called Human Development, published in 2023. It starts off by saying that feeding intolerance is a combination of clinical signs suggestive of a patient's inability to tolerate enteral nutrition, that's food by mouth. It occurs in approximately 75% of very low birth weight infants. Feeding intolerance varies among different authors and clinicians, comprising clinical signs such as increased gastric residual volume, abdominal distension, emesis, which is vomiting, blood in the stool, and the presence of apnea, bradycardia, and desaturations. Many definitions do not include feeding-related cardiorespiratory events. A comprehensive definition was once proposed as the inability to digest enteral feeding. Presenting as gastric residual volume more than 50%, abdominal distension, or emesis, or both, and the disruption of the patient's feeding plan. However, this definition is based on non-specific clinical signs. It does not offer the clinician any guidance on how to differentiate developmental feeding intolerance, DFI, resulting from gastrointestinal immaturity and dysmobility, and pathological feeding intolerance that is associated with ileus due to necrotizing enterocolitis, spontaneous intestinal perforation, and bowel obstructions. In addition, a disruption of the patient's feeding plan may be the result of human factors such as a clinician preference or hesitancy during administration of certain medications or during a bedside procedure, which are not related to the presence of feeding intolerance. The patient's feeding plan is non-specific because feeding guidelines differ across each neonatal intensive care unit. Thus, a more objective, specific definition of feeding intolerance is lacking. Feeding intolerance is a major cause of morbidity in preterm infants, leading to prolonged need for parenteral nutrition and central line catheters, resulting in sepsis, prolonged hospital stay, malnutrition, and poor developmental outcomes. Most of the time, feeding intolerance is a developmental condition related to anatomical and functional immaturity of the GI. However, the clinical presentation of DFI can overlap with the most serious GI pathology seen in pathological feeding intolerance. This leaves the clinician with the challenging task of interpreting the clinical significance of a non-specific clinical sign and symptom. Often, these signs are interpreted incorrectly as pathological feeding intolerance, leading to interruptions of enteral feeds or limitations of feeding advancement in preterm infants without GI pathology. Thus, morbidity that is associated frequently with feeding intolerance is more likely to be the result of the inability to distinguish developmental feeding intolerance from pathological feeding intolerance. So essentially what the author's saying here is that there isn't even agreement what feeding intolerance is, and it's very hard to distinguish pathological causes from natural developmental causes. The claptrap that you're about to hear from the expert evidence is so far away from this reasonable description of a problem here, and a look at how we go about distinguishing one cause from the other. And I'll leave a reference to the paper. We'll just go over this section on apnea, that's stopping breathing, bradycardia, slow heart rate, and desaturation, which is what our triplets are presenting with. In the clinical setting, feeding-related cardiorespiratory events are used routinely to assess for feeding intolerance. Events like apnea, bradycardia, and desaturations sometimes lead to the withholding of enteral feeds, especially if they occur around the time of a feeding period. However, cardiorespiratory events are very common in preterm infants and are secondary to immaturity of respiratory control. Moreover, apnea of prematurity is one of the most common diagnoses in the neonatal care unit. These cardiorespiratory events are non-specific and not indicative of feeding intolerance because they may be related to a variety of other neonatal conditions. Cardiorespiratory changes in preterm infants may be caused by gavage, tube feeding. Why did none of our experts suggest that the apnea attacks that baby O and baby P were having were due to nasogastric tubes? Because it doesn't fit the story. And it continues. The physiological effect of gavage tube feeding in babies include a transient rise in postprandial oxygen consumption. So after the feed, the oxygen demand goes up. A decrease in oxygenation accompanies that, and an increase in heart rate. A decrease in functional residual capacity, so that's the amount of lung that is able to take up oxygen, and a decrease in lung volume. Heart rate, respiratory rate, and oxygen saturation can be also affected by the speed of enteral feed administration. A bolage gavage feed that is administered fast via push increases respiratory rate and decreases heart rate after feeding, compared to slower bolus gavage feeds via gravity. The introduction of feeds into the stomach may lead to volume displacement, resulting in cardiorespiratory events. In low birth weight babies, fast gastric feeding may lead to vagal stimulation. That's the vagus nerve, and the vagus nerve would tend to slow the heart down. That results in apnea and bradycardia. These small infants are more likely to have more respiratory instability during intermittent gavage feeds via continuous feeds. Thus, feeding preterm infants via the enteral route may have physiological effects causing cardiorespiratory changes that are unrelated to feeding intolerance. The writer is clearly telling us that this is a problem in neonatal units that's so common that there needs to be a solution for it. So when it comes to trying to explain what caused the collapses in these babies, the apneas and desaturations and bradycardias, well, we have an answer here, don't we? Because Sandy Bohan will tell us that there's a very muddled and confused strategy to the use of nasogastric tubes in this unit, which is a very straightforward and simple explanation for why the collapses happened in the first place. But we will remember that in baby O, the initial collapse was accompanied by a period of metabolic acidosis and respiratory acidosis, which is not what you want to see. Therefore, we need to separate out the apnea of prematurity, which is the common reason that babies have these apnea attacks. They just haven't developed control the autonomic nervous system and keep the breathing regular, from underlying pathological causes by other diseases such as sepsis or indeed subcapsular hematomas. And the way that we would tend to do this is, if the apnea attacks are profound and result in metabolic acidosis, respiratory acidosis, which takes quite a long time to recover, and particularly if these events are recurrent and just as severe, that seriously points to an underlying problem that needs immediate and thorough investigation, which didn't happen in the case of baby O and baby P. So before we get into the evidence here, it's very important that you know that apnea attacks, bradycardias, desaturations happen all the time in neonatal units. And generally, you can break them into the apnea of prematurity, the ones that self-correct, or the ones that are not even noticed, from the more profound ones that cause acidosis, which are more concerning and need to be investigated. Because we're now going to see the expert witnesses use sleight of hand to keep the jury focused on the collapse and their theory of the cause of the collapse, when in fact there were no investigations carried out to explain why the collapses were happening. There were some blood tests done and plain abdominal x-rays, which are not going to show you what the underlying causes of severe and profound apnea attacks are. And we'll look at one other section from this paper, which is very interesting, and it looks at gastric residual volume. Preterm neonates have an immature GI tract that is characterized by pre-gavage stomach residuals that can indicate poor gastric emptying, gastroduodenal hypomobility, and gastroduodenal reflux. Therefore, gastric residuals should not represent a diagnostic sign of any pathology. Gastric residual volume is influenced by feeding effusion rates, continuous, near continuous, or intermittent, infant position, and feeding tube size. Because of these factors, measurement of gastric residuals is inaccurate and not reliable. Therefore, it cannot diagnose or predict feeding intolerance. Furthermore, the colour of the residual, clear, milky, bilious, bloodstained, or hemorrhagic, is inconsistent in predicting serious GI pathology, including NAC. In addition, checking gastric residuals routinely in the NICU raises concerns about safety, including trauma to the gastric mucosa and loss of important gastric acids and enzymes. Therefore, what the good doctors are telling us is that what you're about to hear from expert witnesses is not diagnostic of anything pathological. And so we start with Dowie Evans. Why not? And here we see Dowie doing medicine in reverse. So Dowie comes up with a diagnosis, and then he goes looking for the science to support the diagnosis when medicine's actually practiced in reverse. We only have the cross-examination on baby P. So Ben Myers, KC, is cross-examining medical expert Dr. Dowie Evans, who has written report on all babies involved in the trial. Cross-examination today is focusing on baby P, one of two triplets who died at the Countess of Chester Hospital. In his report, Dr. Evans suggested the cause of death for baby P was complications from his pneumothorax. Oh, suddenly we have a pneumothorax. He was, however, suspicious of the large volume of air in the stomach and intestines, evident on an X-ray, and we've just heard that all of that is crap. The subsequent reports, Dr. Evans concludes that excess air in the stomach could have splinted the baby's diaphragm, compromising his breathing. An invention of Dowie Evans that he withdrew subsequently in the case of baby C when he made a mistake because Letby wasn't present when the gastric distension occurred. Remember, golden thread number 1, Lucy Letby has to be present whenever an event occurs. Otherwise, it's not an event. Mr. Myers is first asking about efforts to save baby P's brother, baby O, about liver damage. Mr. Myers asks if this could come as a result of chest compressions. Dr. Evans says if the compressions are done properly, this would not be the case. Well, that was not the question. The question was, can chest compressions cause liver hemorrhage? Yes, they can, is the answer. A video is shown to the court showing the correct procedure on providing chest compressions to an infant, so it's the old Soviet propaganda. So then we get on to baby P. Mr. Myers confirms that Dr. Evans had written for his 3 reports concerning baby P, involving complications to the pneumothorax. Dr. Evans said his view was that he could not explain at the time of the first report any other cause for why resuscitation was not successful. Dr. Evans confirms he could come up with no natural cause for baby P's death. Mr. Myers asked about the splinting of the diaphragm Dr. Evans had written about in his report for baby P. He says in the following report, it is necessary to scrutinise the night care from June 23-24. Dr. Evans said it was an option at the time, now not a diagnosis, an option, something that Dowie could use to fit into his theory. He says there was excess air in the X-ray from the night before, which destabilised the baby and meant he was unable to take feeds properly. And you've just read from the other paper that I quoted there that that's not true. He says in light of evidence given by local staff over the past few days, additional air was given to baby P during the morning of June the 24th, which splintered the diaphragm and caused the collapse. He says there were 2 events, access given prior to the X-ray, which destabilized the baby, and further error in the stomach on the morning of June 24th, which is rubbish, according to the other paper, which has a load of references which I'll supply to you that explain why that's not the case, and that Dowie is simply making this up. He says that that is a more accurate way of explaining the events. No, it's not. It's the Dowie way of explaining events. Dr. Evans says the most recent of his reports is from 2019, and he has since had a far better understanding of the clinical sequence of events as a result of the trial in 2023. Remember the publication date for that paper? Trying to put this whole apnea, collapse, air in the stomach, feeding intolerance picture into some kind of logical sequence that you can think your way through. That was 2023. Dowie hasn't practiced for at least 10 years before that paper was published. He said he was more concerned from his evidence at the time about the night care when baby P was not taking feeds and had a bradycardiac event. He says he does not believe baby P would have collapsed without an additional administration of air in the morning. And again, remember, we've already heard that apnea and bradycardia are very common, and if they're severe, they are probably indicative of underlying pathology and are not related to the amount of gas present in the stomach or any kind of vomiting or reflux or distension. Mr. Myers said Evans had shunted the sequence to the point where Lucy Letby was on duty for a day shift on June the 24th. Dr. Evans denies this, saying, quote, "If he wanted to put Letby in the frame, he would have included events from June 23rd day shift when Letby was also on duty." Dr. Evans says, wait for it, an extra dollop of air would have been administered just before 9:40 a.m. on June the 24th. So we have the paper telling us that there is no real relationship between distension, reflux, all these other things, and bradycardia events. But this little man is now telling the jury that he can predict not only the time of the event, based on no evidence except that an apnea attack occurred at that time, and he's going to quantify the precision of the attack by the use of the word dollop, which is not a medical term. Dollop is something you might use, I suppose, if you're ordering ice cream. This is not expert testimony. This is farcical storytelling. When did the pneumothorax occur? Is it already there at 9:40 in the morning? We don't know. Dowie doesn't know. Can a pneumothorax cause an apnea or bradycardia? You better believe it can, because the man on the street term for a pneumothorax is a collapsed lung. He says baby P could have been suffering the consequences of an administration of air from the previous night by the following morning, but that would have been insufficient to cause a collapse, not without the further administration of air, which is just bullshit. Mr. Myers said that Dr. Evans is coming up with ideas and theories rather than relying on medical evidence available and the medical knowledge base. Dr. Evans says that is incorrect. No, that is not incorrect. Mr. Myers says Dr. Evans has invented an extra dollop of air. Yes, he quite literally has, on the stand. Dr. Evans says he is satisfied from a clinical perspective about the additional administration of air on the morning of June the 24th. But what is the clinical evidence for that? Because he doesn't know what the preceding volume of air in the gut was before the extra dollop. He doesn't know what the absolute amount of air in the gut is required to cause a crash, and he doesn't know whether the baby is already bleeding from the liver or that the baby already has a pneumothorax. So he has no clinical basis on which to make these claims. They're just stories. He says it is not a guess, but a clinical assessment. And I've just told you that it isn't a clinical assessment. And it isn't even a guess. It's just a shot in the dark. A blood gas result for baby P is shown to the court from June 23rd, showing normal gas readings. Dr. Evans said an administration of air would not necessarily lead to a baby crashing. So, administration of air does not cause the baby to crash. Well, what does it cause then? It would lead, according to Evans, to the baby not tolerating milk. Therefore, according to Evans, air through a nasogastric tube does not cause crashing, it causes feeding intolerance. But we already know from the papers that we will supply that this is simply not the case. It's a mistake to interpret air in the gut or vomiting or gastric residuals as anything to do with feeding intolerance, or indeed anything else. These are the common everyday things that happen in preterm babies because they're immature. They're windy, sometimes they stop breathing, sometimes their heart slows down. People have theories about why it happens, but in all honesty, we don't really know. The wee man has actually shot himself in the foot here because he's surprised even Sandy Bohan with this one, and he's definitely floundering a bit, and he goes off into the realms of philosophy to create more distraction and draw the jury's attention away from his crazy talk. You see, he thought he might slip that one past Ben Myers, but he didn't. Myers pointed out that, well, the stomach was full of gas the night before and the blood gases were fine, which is exactly what the paper I mentioned says. So Dowie goes off into full Socrates mode here now, and he says, there is more to a baby than a pair of lungs. There is also the stomach and intestines. Well, it's about 50 or 60 systems, maybe 2 or 3 billion cells interacting with each other every second. But we're in the realms of philosophy. The first administration of air did not affect the breathing, he tells the court, but led to baby P being unable to feed. The second administration of air the following morning caused splinting of the diaphragm, he says. Mr. Myers repeats that Dr. Evans had invented a theory of a dollop of air to get it over the line, and Dr. Evans denies this. Now, I beg any doctor listening to this claptrap here from this man to seriously consider anything this doctor says. This is pure fantasy, and it's improvised fantasy. He's making this up as he goes along in a murder trial. He has since changed his mind and withdrawn some of the evidence that he gave. The man is an absolute train wreck, and the writings and opinions of Dowie Evans cannot be allowed to stand. Then we have Owen Arthurs wading into the ridiculous chaos that this man has created, and he tells the court this is gas throughout the gut. This degree of gas is quite unusual in a baby like this. Big deal. He said potential causes were infection and necrotizing enterocolitis, a common bowel disorder in preterm babies, but he leaves out meconium plugging, which is the most common cause in preterm babies. And he doesn't tell the jury that X-rays usually don't pick up meconium, and you need a contrast X-ray to see the meconium that's blocking the gut. But we don't have that. An alternative explanation, says Dr. Arthurs, is the administration of air via a nasogastric tube. But he doesn't set out to explain to the jury that air can get into the nasogastric tube while it's on free drainage, and that it would be impossible to distinguish air that had reached the gut by that method from air that reached the gut by the fantasy that Lucy Letby injected air into the baby. And I cannot but wonder, now that Dowie has withdrawn the nasogastric tube injection of air as a cause of death in baby C, is Owen Arthurs prepared to withdraw his diagnosis of injection of air by nasogastric tube as well? Dr. Arthurs came to the same conclusion regarding an X-ray of baby O captured hours before his death. He said this shows a lot of gas in the stomach, small and large intestines. Yes, meconium plugging. This is more than we would expect in a normal baby. But baby O and baby P are not normal babies. But what does the literature tell us about this? Well, one study showed that substantial or excessive air in the stomachs of over 1/3 of neonates with nasogastric tubes because of improper tube placement, inadvertent swallowing of air, pressure into the tubes, and that all of it can cause excessive distension throughout the abdomen, simulating necrotizing enterocolitis. And it can look like feeding intolerance. And if it's really bad, it can cause respiratory compromise. Why didn't he tell us that? And next we get to Sandy Bowen, who might be in a position to help Professor Owens out. So Nicholas Johnson is asking Sandy Bowen, and she said that she has completed a total of 5 reports for baby P. Dr. Bowen confirmed she had looked through all the clinical notes for baby P, including one by Lucy Letby, where she had written about the NG tube being on free drainage at 8 a.m. A note at 6:39 a.m. by Sophie Ellis from the night shift said baby P's abdomen was soft and non-distended, with 25 mils of air aspirated, and NG tube placed on free drainage. Letby later noted at about 9:30 a.m. baby P had an apnea brachydesat with a mottled appearance, requiring facial oxygen and neopuff for approximately 1 minute, abdomen becoming distended. A consultant doctor was called to the nursery where baby P was. Baby P had a speedy recovery that morning, and Dr. Bowen is asked if that was normal. Dr. Bowen says no, it was not. So what do we know about sudden desaturations in 33-week neonates? Well, they wouldn't be considered common, but they can happen. And any baby before 34 weeks gestation is prone to episodes of apnea, bradycardia, and desaturation, which are called ABD events. And these events can occur because of immature respiratory centres or immature lungs, but in general, they should be taken as a warning sign, particularly given that the baby's identical triplet brother died the day before, because potential causes are mucus plugging, sepsis, pneumothorax, seizures, all kinds of nasty things. And what did the consultants do about it? Dr. Bowen tells us that the baby went on to have another desaturation at 11:30 a.m. and this time was given adrenaline and paralysed with a drug to aid ventilation. His circulation was restored, but he continued to deteriorate throughout the day. And these people want you to believe that a nurse did this with a dollop of air in a nasogastric tube. These people must think that we're all batshit crazy. But it appears we have allowed baby P to deteriorate so rapidly that he now needs adrenaline. Events are again totally out of control and beyond the capability of these people to rescue the baby at this point, proving once again that poor baby O and baby P were out of place and out of time. But it only gets worse, because Bowen is now telling the court about the adrenaline doses which were administered to baby P throughout June 24th, their concentrations and totals. Dr. Bowen explains the rate of adrenaline administered to baby P according to the medical notes was not calculated correctly. It was double what it should have been. Dr. Bowen says the excess adrenaline would not have had any adverse effect to be administered after baby P had collapsed and was already suffering metabolic acidosis. She says it is impossible to quantify any effect on lactic acidosis, and that is completely untrue. Remember what we talked about before, glycolysis. Glycolysis is the breakdown of glucose into energy using oxygen, and it runs through what's called the Krebs cycle. And in this cycle, the glucose is broken down into smaller and smaller parts, each of which have a different name. And one of those parts is a substance called pyruvate. And it just so happens that independent of anything else that adrenaline does in the body, it promotes the production of pyruvate. Now, if there's enough oxygen available and enough mitochondria to process that pyruvate, it will move through the full Krebs cycle. If there isn't enough oxygen, as in this case, to allow the pyruvate to move through the full Krebs cycle, it will move back to lactic acid in a ratio 10:1. And I leave the full formula for you in the show notes, meaning that there is a relationship between adrenaline and pyruvate and a relationship between pyruvate and lactate, which is independent of everything else. Adrenaline will only ever do one thing with regards to lactate when there isn't enough oxygen for the pyruvate to complete the cycle. Adrenaline will always increase lactate and make the blood more acidic. Another doom loop. And Sandy goes on to say that it did not adversely affect the blood pressure or heart rate. Dr. Boone tells the court that she was concerned about the gas in the initial abdominal X-ray taken as a precaution with no concerns about the abdomen, but it was full of gas and the abdomen was distended right through. The X-ray was abnormal. Now, Sandy is blowing a hole through the previous evidence that when Dr. Gibbs did his examination, he found that the abdomen was soft, the bowel signs were present, and that this was all reassuring. But now she's telling us that the X-ray proved that it was anything but reassuring. So much for relying on examination and abdominal X-rays for telling you what's going on inside a baby's gut. They're absolutely useless. But they told the jury that this was all very reassuring. If they're now putting weight on the fact that there was so much gas in the abdomen and that this gas was so dangerous to the baby, if it was so dangerous to the baby, why didn't they do anything about it? Because of Dr. Gibbs' reassurance, they continued to feed baby P throughout the night. But the prosecution is dragging Sandy away from the real issue here. Why was the baby given so much adrenaline? A poisonous dose of adrenaline, double the amount. And then she continues to hang herself with the same logic. She says, throughout the night, baby P became intolerant to feeds. No, the baby was intolerant to feeds before that. And the abdominal distension was reduced. So contradicting Dr. Evans, she says that the abdominal distension does not cause feeding intolerance. And she's already told us that an examination and an observation doesn't tell you if there's abdominal distension present, because it was found in baby P by accident as a precaution. But even if it was causing splinting of the diaphragm, Sandy's telling us that it's gone. It was gone by the morning. So the top-up theory or the dollop theory is a load of bollocks, according to Sandy. And then she says that baby P's abdomen became distended and loopy in the morning, and that was difficult to explain, which is putting Lucy Letby back in the frame. But it's not difficult to explain. She has explained it herself. She tells us that examinations and observations are not sufficient to tell you whether or not abdominal distension is continuing. Why, therefore, would you be surprised to find it still present in the morning? And then, trying to save a little bit of dignity, she says that baby P should have had a further X-ray sooner after the first collapse and more attention paid to the pneumothorax. Does that mean that we discovered the pneumothorax by accident as well? Nothing would surprise me. But we now bring pneumothorax into the equation, and why do we have a pneumothorax? Did Lucy Letby cause that as well? Apparently not, because she goes on to say the ventilatory pressures were quite high for baby P, who had no underlying lung disease. This was not a criticism of the staff, Dr. Bowen says. No, this is what I mean about the road to hell. It's perfectly fine, staff, to keep ventilatory pressures very high, because if anything goes pear-shaped, we can always find you a murderer. For the cause of the collapse, she says, she could find no reason why there was excess air from the previous night and there was splinting of the diaphragm. Contradicting herself, yet again, babies can collapse without reason.
Because we didn't look. We don't know if there was abdominal distension. We didn't do an ultrasound. We didn't do any investigations to find out why this was happening.
And she says that baby P had no evidence of infection and no evidence was found. But we all know that evidence for infection is not always found post-mortem. And again, I will leave you the references. The jury is clearly being misled with this evidence. Perhaps not intentionally, but certainly through ignorance. And she puts the cherry on the cake and she says that her conclusion was was administered via the nasogastric tube. She has absolutely no evidence for this whatsoever and is tying herself in knots, contradicting herself. And she cannot explain why BBP had further collapses on June the 24th. Mr. Johnson said one more point to raise with Dr. Bowen. He asked her about the adrenaline dose rates being double what they should be, and if that was beyond a safe limit. Dr. Bowen explains the limits, in accordance with guidance, would have been within limits, but the higher rate, the more the risk of side effects. Higher doses would be administered in extreme circumstances on guidance from a consultant. Side effects would be rising blood pressure, rising heart rate, irregular heart rate, and with very high doses, constricting of blood vessels. But she forgets to tell us that it would also increase lactic acid doses and that, in general, there are no studies that support the use of adrenaline at all in preterm neonatal resuscitations. And then Mr. Myers has a go. He's asking Dr. Bowen questions. He asks about the need for an X-ray to have been taken sooner. Dr. Bowen said that that would have been needed when looking for the cause of the collapse. So Dr. Bowen has just told Mr. Myers that without that X-ray, we can't know what the cause of the collapse was. Mr. Myers says Dr. Bowen had in her report. Mr. Myers says Dr. Bowen had in her report identified a particular issue with the adrenaline, which she said recorded at a high starting dose. Mr. Myers says the ventilator settings were also high. Dr. Bowen agrees the settings did not need to be as high as the oxygen requirement was not so high. Dr. Bowen says a pneumothorax could have contributed to the collapse, but would not have caused it. Of course, it could have caused it. What she's saying here is that the ventilator pressure was too high, going into lungs that didn't need ventilation at all because they had no underlying lung disease. Therefore, we're now getting pressure from above and below, from the ventilator and from the distension. Which of the two is actually splinting the diaphragm? The machine that's pumping air into the baby, or the dollop that Lucy Letby gave many hours ago? This stuff is so beyond ridiculous. It's actually sad having to read it. Mr. Myers says the care offered to baby P was, in Dr. Bowen's words, muddled and unusual following the baby boy's collapse. That's a bit like your evidence, Dr. Bowen. Dr. Bowen said questions need to be answered about the ventilatory strategy and the high doses of adrenaline, but the latter issue had been raised and answered by doctors in the court, answered inadequately by doctors in the court. She added that neither of these issues had caused the initial collapse for baby P, but we don't need a cause for the initial collapse. Babies can collapse all the time without a cause. Mr. Myers asks about the rate of adrenaline administration. Dr. Bowen says the starting dose depends on what the child has, their condition, and what they have been administered before. Dr. Bowen says doctors wanted to give a large dose to kickstart the heart, as BBP had suffered a cardiac arrest. Even at this rate, the dose was ineffective, Dr. Bowen said. You won't be surprised to know that there are lots of reasons why adrenaline doesn't work in preterm neonates, not least because cardiac arrest is often secondary to asphyxia, rather than a primary cardiac cause. As usual, I'll leave you the information in the show notes, but again, the jury is being misled. There isn't even an agreement over what is the proper dosage for the use of adrenaline in preterm neonates, if you're going to use it at all. But the hammer keeps falling on Dr. Bowen and Dr. Dowie Evans when Myers talks about the very high lactate reading BBP had at 10:46 a.m. That, I believe, is 6 hours before poor BBP died, because in my opinion Dr. Gibbs should have referred BBP to Alder Hey or Liverpool Women's Hospital the night before, when they had made such a mess of the resuscitation of Baby O. We're deja vu all over again. They're making such a mess of BBP now that he hasn't a chance. If he has a very high lactate at 11:15 in the morning, he was effectively dead at that point, and his parents should know it. There is a very, very clear correlation between very high lactate levels and mortality. And Myers goes on to show that Sandy was caught out by Dowie's little improvisations, because he says that in her reports, it's not mentioned in Dr. Bowen's reports about any additional administration of her that morning, and Dr. Bowen says there is not. He says the only evidence of abdominal distension is from 4 a.m. Dr. Bowen says it was identified then, it went away, then it is noted as appearing distended and loopy again in the morning. But we know that's a crock of shit. And Myers says if Dr. Bowen is saying that the collapse happened because of distension of the bowel from the night before, and Dr. Bowen disagrees. They've tied themselves in knots with this bullshit at this stage, and they have nothing left but default to the golden thread standard that the collapse was unexpected and completely unexplained. The collapse happened 10 minutes after Dr. Anthony Uku examined BBP and found the abdomen moderately distended and bloated. Dr. Bowen says the issue she had had in the course of the trial is there did not seem to be consistent practice among the nursing staff in the aspiration of feeding tubes. But in this case, when there was a 25 ml of air aspirated early on June 24th, that was normal. Benjamin Myers continues to ask Dr. Sandy Bowen questions. He refers to the case of BBG in reference to milk and pH levels, where a pH level from the aspirate was recorded as 4 on September the 7th, 2015 at 2 a.m. Dr. Bowen said it was a pH level of 4 and very acidic, and there was not milk in the tummy, as milk would buffer the pH level and neutralize it. But again, we're now making mistakes at GCSE level chemistry. Human milk is acidic. The stomach is acidic. One acid cannot neutralize another acid. pH stands for potential hydrogen, and all it is a measurement of free, positively charged hydrogen ions. If the logarithmic count is above 0, it's alkaline. If it's below 0, it's acidic. 0 is neutral. Once a baby feeds, it will produce enough acid to keep the pH between 5.5 and 6, because that's the ideal pH level to metabolize the casein and whey, which are the two proteins in human milk. If you're pulling up aspirates that are below 4, 3, 2, 1, they're mostly made up of stomach acids and residuals, and the human milk is long gone because digesting human milk has a pH of around about 5 to 6. And we can see the deterioration of baby P from the night before, June 23rd, 8 p.m. 14 mils of milk aspirated, pH level of 3, that's not milk. Mr. Myers says 20 mils of milk is aspirated several hours later with a pH level of 3, that's not milk. Dr. Bowen said milk would buffer the pH level. No, it wouldn't. She said the trial had moved through so many babies since baby G, she would need to know the clinical context for baby G. You don't need to know the clinical context to know that one acid won't neutralize another acid. And pop-up prosecutor attempts to rescue the situation. He rises to clarify the meaning of buffer. Dr. Bowen said it would effectively neutralize it, and I've just told you why it can't. Nicholas Johnson rises to clarify pulmonary hypertension as a possible diagnosis. So this is another one. Look at this hand, don't look at the other. Dr. Bowen says it can affect blood flow and blood pressure. Well, so too can acidosis left for hours. I prefer to watch the other hand. And they very cleverly move into a discussion on a disease that the baby didn't have in order to confuse the jury. But for me, that's a car wreck. And finally, we have Dr. Marnarides, the pathologist, weighing in to see if he can float the boat. And he says about baby P, he's presenting a photograph of the baby boy's liver taken at post-mortem to the court. The images show small bruises on the outside of the boy's liver. So that's 2 boys with bruising in the liver. Dr. Marnarides tells the court that the bruising, although a lot smaller, is in the same area as it was found in baby P's brother, baby O. The court heard yesterday that baby O suffered a liver injury akin to a road traffic collision, and we dealt with that in the previous podcast. The medic said the bruising found could be the result of CPR. Asked whether it could be another impact injury, he says, I don't have enough to say that. Well, he didn't have enough to say that baby O was an impact injury either. And he didn't mention at all the fact that somebody likely stuck a cannula into the baby's liver, baby O's liver, at the time of the resuscitation, which is going to cause it to explode under that amount of pressure. And I'll leave you the link in the notes. He keeps going on about probabilities and possibilities. I wondered if he ever stopped to think, what was the probability that him, a man of Greek origin, whose family have survived millennia of pestilence and plague and war, would actually be given evidence against another girl from England whose family had done the same? I'd say the probability of that happening is in the trillions to 1, but yet, there we are. It happened. CPR, whether done right or wrong, can cause bleeding in preterm neonate's liver. Babies can be injured at delivery, either from cesarean section or from normal delivery, and that may not appear straight away, and most hematomas of the liver in preterm neonates are fatal. And I will leave you the information about that. I have to say, I can't wait until the professional reports come out about the deaths of baby O and baby P. Remember, baby O was the first case that Darry Evans was given. And Darry Evans told us that he knew within 10 minutes of reading those notes that there was a murderer on that ward. And that's how this whole fiasco started. But by the time he reaches court, by his own admission, he has written 5 reports on baby O, and the initial cause of death that he came up with is no longer the cause of death by the time he gets to court. We can only conclude from that Darry was looking for a murderer from the get-go, and it didn't particularly matter what the means of murder or the mechanism of murder was. In his interpretation of the evidence, he was infinitely flexible, and he's so lacking in self-awareness and is so grandiose in his image of himself that he thinks he can keep on talking the way he has and change his mind after the event. Baby C didn't die the way he said, and neither did baby O. With any luck, this might provide a route back to the Court of Appeal. It's very hard to know what caused the death of these babies. I can't wait to see the professional report. I've given my opinion. I think the babies died because of very poor resuscitation. I think they got ill because the staff were simply too inexperienced to deal with these types of babies in the first place. They're monochorionic triplets, 33 weeks gestation, and their so-called intensive care unit was already full when they were born. Triplets have much higher mortality than twins or singletons, and monochorionic triplets, depending on whose figures you look at, have as much as 5 times the mortality rate of a singleton at 33 weeks. What we need to know, and what we're not finding out at the Thirlwell inquiry, is who made the decision to admit these babies to this unit. Why did Dr. Gibbs not transfer baby P immediately after baby O had died, particularly when they told the parents at the time that they didn't know why baby O had died? And were they being honest and frank with the parents of baby O and baby P? Did they tell baby O's parents that someone stuck a cannula into the abdomen of the baby without ultrasound guidance? Did they tell them that they had used sodium bicarbonate when they shouldn't have? Did they tell them that they had overpressurized baby P and that they had used a toxic dose of adrenaline, which may not have been of any use anyway, but was certainly going to have a profound effect on the acidity of the baby's blood and was certainly going to compound the cause of his death, which in the end was metabolic acidosis? I don't think they told the parents any of this. I don't think anyone has told the parents any of this. And I think that's an appalling injustice and contempt for human life and for society at large. I don't think you need to have much training in medicine to know that if you overpressurize these tiny little babies, you're going to cause harm. If you use high-flow nasal cannula on these babies when you don't have any reason to use it, you're going to cause harm. If you give massive doses of adrenaline, you're going to kill babies. If you overfeed them when they're not clearing meconium, you're going to cause problems that can eventually accumulate in the disaster that we see here. Most of medicine is getting the basics right. Prevention is definitely better than cure. If I had been given the files of baby O and baby P by Cheshire Police, and I'm not even a neonatologist or a pediatrician, I would have been deeply disturbed by what I read. This is basic stuff that should never have happened. This evidence is absolute rubbish that ties itself in knots and is typical of all the stuff we've heard in this trial, from the air embolism theory through to the nasogastric tube theory. It's all absolute rubbish, and it cannot be allowed to stand. So in the next episode, we will finish off with the case of baby Q, even though Letby was not found guilty for that particular crime. It will finish this series, and I will have covered all the babies, and I hope that you'll learn a little bit from this about how doctors think, how they should think, and what was probably the cause of death for baby O and baby P. And we'll have to wait until the professional reports come out to correct anything that I've said that's wrong. So we'll see you in the next episode. Bye.